Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now here are your hosts, vestibular physical therapist Dr. Abby Ross and Dr. Danielle Tolman.
Welcome back to another episode of Talk Dizzy to Me. I'm Dr. Danielle Tolman, a vestibular physical therapist, and as always, joined by my co-host, Dr. Abby Ross, also a vestibular physical therapist and neuroclinical specialist. And today we have a really super cool episode for you guys. We are also joined by two guests. One, definitely a fan favorite. We've got Jeff Walter with us, and then a newcomer, Dan Streeter. So Jeff, let's start with you. Can you just give us a little introduction, introduce yourself, and then we'll pass it over to Dan.
Sure. I work at Geisinger Medical Center in central Pennsylvania. I only see patients with dizziness and balance problems. I have an additional interest in teaching and research. I have a lot of courses on MedBridge if you're interested. I just turned 50 like a week or two ago.
Happy
birthday!
Yeah, real exciting. You want to know what I got for my birthday present, by the way, Danny?
What'd you get?
I got a colonoscopy. That exciting.
That is very
include this in the episode.
All right, Dan, why don't you introduce yourself and tell us a little bit about you?
Sir, I've been at this for 12 years as a PT, seeing kind of a combination of orthopedic and some vestibular patients for sure. My first, journey on this was when my boss looked at me and said, "Do you have any experience treating patients who are dizzy?" I said, "I just got out of school about 3 months ago, so yeah, it's still fresh in my brain." So I kind of took a stab at it, and it led us into the fact that we need to know more about this. And so we had Sue Whitney come to our office and gave us a 2-day sort of crash course on what to do for folks in an outpatient orthopedic setting that might be presenting like this. And it sort of made me want more. So went in for, a few different continuing education courses over the weekends. Definitely saw a few of your courses, Jeff, on MedBridge. Danielle came to our office a couple of years ago. During that time frame, I also became a Maitland therapist. And so a lot of that has to do with provoking symptoms, which is a lot of what we do as vestibular therapists. So, and then we've recently got the infrared goggles at Danielle's recommendation. And so seeing the video that you guys will see today has been one that I've watched a gajillion times, and so thankful that we've made that recommendation and embraced this piece of technology, because frankly, I don't know how we would treat these complex cases without them. So, but glad to be here. Thanks for having me again.
So this brings us to why we're here today with this specific type of episode. For those of you listening on the podcast, I'd recommend checking this episode out on YouTube, because we do have some visuals, but we'll do our best to talk through them. Dan had sent me this really cool video. He's like, there's a lot going on here. He's like, check this out. And when I first saw this video, just, by itself, I thought it was a great example of how things don't necessarily present the way you think or anticipate they're going to present during positional testing. So this video today is an infrared goggle video of a patient going through the positions of an Epley maneuver. And what's so interesting about it is we see a lot of different types of nystagmus here that we want to talk about in isolation. So all of you vestibuloholics who are watching and following along, I know you're going to be thinking of, well, what did he look like with this? Well, what happened with that? And what else has been going on? We want to purely look at this just as a problem-solving video in isolation. So that's what we're going to do. We're going to look just at this video. We're going to talk about what we're seeing, and then what kind of implications that testing might have, and what we'd like to do with that patient in theory moving forward if they were sitting right in front of us at that moment. So without further ado, I'm going to pull up our video here. We're going to hit play. And again, this is a patient in infrared goggles. We're going to take them through an Epley maneuver. In the video, you'll see what position they're in as it's labeled. And we're just going to kind of chat along here. So here we go.
By the way, our YouTube channel is under Balancing Act Resources if you want to pull that up.
All right, so we're in position 1 of the Epley with that head turned to the right, lying down flat, keeping that head turned. So what type of nystagmus are we seeing here, Dan?
Seeing a burst of geotropic nystagmus, so to the right.
Okay. And we know from Ewald's laws that nystagmus is generated by the canal that's being stimulated, right? So in this position, we typically test for a posterior canal involvement. But here we're seeing horizontal nystagmus. So Jeff, what does that tell you looking at something like this right away?
Well, a couple comments to maybe clinicians that aren't as experienced. Sometimes when you see intense nystagmus like this, you may think, oh, man, I can tell it's horizontal, but it's really difficult to discern which direction the fast phase is in. Bear with it, because as that video played out, it was more evident that the fast phase was to the right as the nystagmus slowed. So when you see really, really violent nystagmus, just stick with it. And you can see as the video plays out that it does seem to develop the theme where the fast phase is quicker to the right. So when you see a burst of geotropic nystagmus that dies out, the first thing you should think about is horizontal canal canalizes. And the nice thing is there's really not a large differential of other entities that can generate bursts of geotropic nystagmus. So a burst of geotropic nystagmus that crescendos and decrescendos and makes your patient vertiginous is very specific to canalithysis of the horizontal canal. There's not really a large differential there. Other things that can create geotropic nystagmus, like a light cupula or michelobe, would cause sustained nystagmus, not a burst that crescendos and decrescendos like we just saw.
Yep. I think everyone's on the same page. Here's where things get a little bit interesting moving forward. So that burst of geotropic nystagmus settled down and the patient hasn't moved. They're still in that first position of a right epi. So head is turned to the right and they're extended backwards. And now we're seeing a reversal. So now we're just looking at this, persistent apogeotropic type of nystagmus. Now, I'll admit, originally I thought that maybe this also meant the patient had a cupulolithiasis potentially on top of having canalithiasis. But Jeff, you were mentioning before we hit record here that might not necessarily be the case, that there's something else to consider here. So what else can we consider here with this reversal of nystagmus without any movement?
Yeah, I think that we're very likely looking at what's called short-term central nervous system compensation. So maybe if we can pause the video for a second. Mm-hmm. So this patient was put back basically in a right Dix-Hallpike position, which is similar to Epley position number 1.
Correct.
And the patient experienced intense geotropic nystagmus beating to the right. So quickly, your nervous system recognizes that that's an error signal, because you have other senses that are feeding your brain the information that, hey, you're not moving. This is error. It's a mistake. So your brain attempts to help you compensate by generating the reverse eye movement. So the patient was having a burst of right beating. So there's leftward eye, the compensation for that would be nystagmus beating to the left. And so it's like the brain is sending a firefighter to a fire that just went out on its own, but is still dousing it with water, and it's causing the nystagmus to go in the opposite direction. We see this most commonly with horizontal canal BPPV, especially canalithiasis, and it's more common when the nystagmus has been intense, like what we just saw with this patient. So that's the first thing I would think about with that, is that's short-term central nervous system compensation that is too late and no longer needed with this patient, because the patient just had a transient asymmetry theoretically from horizontal canal canalithiasis.
That's a really good reminder. I mean, I'm aware of that phenomenon, and for some reason, even after watching this video multiple times, that didn't even occur to me as a possibility, because I had in my head that this was just positional related with crystals. And this is one of the reasons why I love doing stuff like this and being able to pick the brains of other clinicians, especially like a superstar like Jeff, because it's like, oh, that's right. Having that little bit of reminder is so, so important. So I think that's a really good point, Jeff. And
that phase can be quite protracted in patients, often longer than the first phase you saw. So it's often it's almost always lighter. I've never seen it be stronger than his initial phase. So it's usually lighter and more protracted, this compensatory phase. And patients can have some mild oscillopsia with it and feel a little unsteady, but it's not as symptom-inducing as the first phase we saw with the patient.
Yeah.
It is interesting to note too, and maybe you can comment on this, Jeff, is he had a real violent burst of geotropic nystagmus and had almost minimal symptoms. I mean, he had a fog, he was very minimally symptomatic with this particular position. And I know that we see all different sorts of dizzy patients. You've seen a plethora more than I have, but you got people that have maybe a couple of beats and they're super symptomatic, right?
Yeah.
So just to comment on that.
What was the patient's age?
50, 54-ish.
Anxious or laid back?
Laid back.
So that's really interesting, Dan. So the term that we're starting to use for patients who, for example, we do caloric tests and we're applying peripheral stimulation to the patient and we get nystagmus with the test and they don't care one iota, like they have no sensation they're even moving. We're terming that vestibular agnosia. So that means your vestibular sensations are not reaching your higher cabbage in your brain. Like you just don't have a conscious perception of it. Interestingly, it still creates postural instability.
Yeah.
So patients are still unstable on their feet, but they don't have like this conscious sense of movement. So that would be unusual, but I think that that's very plausible if you have a patient I see it more in males who are just kind of laid back, that they're only disturbed when they're in a threatening posture. And if they're laying supine on a bed, no matter what you're doing in the way of vestibular stimulation, they just don't care too much because they're not threatened by it.
They just talked about vestibular agnosia at the International Conference for Vestibular Rehabilitation in Minneapolis. They had a whole presentation on it, and it was pretty darn wild to see some of the video examples of these patients with this. I mean, Abby, if you remember, that was like the craziest high amplitude nystagmus I think I've ever seen. And this patient it didn't phase him one bit. Like there was nothing going on. So that was a really interesting concept to bring up.
That sounds like it could be a future study someday about personality traits and whether or not the agnosia presents more in laid back individuals like you see clinically, Jeff.
Yeah, I agree. I also think it'd be interesting to look at vestibular agnosia and fall risk, because I think it's a risk for falling when you are unaware of what your ear is telling you until you're falling. I think that's a risk for falls potentially, but I think there's a little bit of literature on that, but it's definitely something that probably needs to be looked into further. One question for Dan, was this done with fixation denied? In other words, patient in the dark, or was he fixated?
No, he was in the dark.
It'd be helpful when diagnosing canalithiasis of the horizontal canal. If your patient's not disturbed by it at all, you might want to retest or remove the cover and see if the patient at least tells you things are moving in the room, because with brain origin nystagmus, it's much more common for a patient not to be disturbed by it. So
got it.
It'd be interesting to know if he had that violent of nystagmus with fixation, does he at least report to you, oh yeah, things in the room are moving or shifting at least? I think he probably would with it that violent, but in the dark, he just may not. He obviously won't have the oscillopsia.
Makes complete sense.
So you might want to check that.
Quick question too. So having the patient with fixation removed, would that potentially amplify or create a greater amplitude nystagmus for that with that central nervous system compensation? We would maybe see less of it if they had fixation, because you can suppress the horizontal nystagmus.
Right.
Yeah. A comment on that would be, you ain't suppressing what happened in the beginning of that video, whether your fixation present or not, because that nystagmus was so violent. Mm-hmm. But you could suppress that second phase if you could gaze at something. It's such a lower velocity. We're better at humans at suppressing low velocity nystagmus. So that second phase could be suppressed. So if you don't have goggles, you really won't see it, which actually might have helped you in this case because it creates confusion.
So not to get off a little bit, but I did play with the light a little bit and had him fixated, with gaze holding, and his nystagmus was certainly suppressed in those positions. So that makes sense.
The goggles are a blessing and a curse sometimes, because they give you lots of information, but sometimes it's too much. You get things that really aren't clinically directly relevant to why your patient's seeing you there. That's, I think, one of the challenges of doing vestibular is sorting out what's relevant from what's not really relevant to why you're seeing a patient, because you get sometimes more than what you need.
Sometimes it's about triaging too, right? Like trying to identify what to treat first and then watching things kind of fall into place as you start to peel back those layers.
Right.
Cool.
So if we could glean a clinical pearl from what we've discussed so far, one might be, if you are confused because the nystagmus appears to change, try retesting with fixation.
In this case, I like it. There's lots of clinical pearls. I mean, it's crazy how much information we can get just from all getting together like this and discussing. I love it.
I can't wait to tell Mark that he might be vestibularly agnostic about the whole thing. He's going to get a big kick out of that.
All right, let's move on into the position 2 of the epley. So the patient's now rolling their head, keeping their head extended and rolling their head to the left. So now that we're essentially in this almost like a left Hallpike position, we're seeing a little bit of left torsional upbeat nystagmus at this point in time. Would you guys agree?
Yes.
I'm still assessing. I'm not sure I really saw a lot of upbeat. I think there might have been some left torsional component, but I think a lot of it's geotropic.
All right, so that's interesting. So looking at the torsion, I would have thought that there was some upbeat there, but kind of playing it back now, you could make the argument that it's just pure torsion.
One thing that helps when you're looking for upbeat is the lids should bounce vertically when you see upbeat.
Okay. I'm just replaying this a couple of times for us. So as we're
like right there, the lower lid's not bouncing vertically.
Yeah,
that was. Then as it plays, it seems to right there more so.
Yeah,
I see that.
You see it more in the patient's right eye versus the left eye. I don't know if there's a little bit of difference in the bottom lid, but it definitely switches to just a geotropic nystagmus for a little bit as well.
Yes.
Which then looks like it kind of just slows down and hangs out in this almost like a persistent geotropic position. The patient kind of hangs out here for a while. It was, and there again, not very symptomatic here at all, Dan.
He was in that fog.
But not dizzy.
Not super dizzy, no.
Well, I have a comment.
It does seem like it's slowing down.
Yeah. What's your comment, Jeff?
Well, one thing is we never really, from position 1, the left beats really never stopped. That compensatory phase from position 1 never really stops. When you roll him over to his left, you still got that bull rolling downhill, his tendency to have left beats.
Yeah.
I think when you first turn his head, it increases in intensity and then kind of.
So here we still have a pretty good generated left beating response moving into position 2.
Right. It enhances, but
yeah.
Remember, he never really stopped with the patient never really had cessation of the left beats in position 1.
So who are we to say that it's not just a continuation of
that big burst he had at the beginning, somewhat?
Yeah.
But I wouldn't, the accentuation when you first roll him is probably horizontal canal canalithiasis enhancing the geotropic nystagmus, and then we're still dealing with a little bit of the short-term central nervous system compensation from that first mega burst the patient had when we brought him back.
Well, that would make sense then in terms of nixing the theory of cupulolithiasis, because in this position, you would expect to see if that there was cupulolithiasis, a slowing down of this geotropic nystagmus, it kind of stopping and then going into a reversal of apogeotropic, correct? In theory?
Yeah, but I don't want to get too complicated here, but this patient could reverse in this position.
If you wait long enough.
They could have another bout of short-term central nervous system compensation from the geotropic burst beating to the left with turning the head left.
Okay. Should we move on to position 3? Anything else to comment on there?
I think if I saw that in the clinic, I would put in my back pocket that I need to double check left Hallpikes with this patient when I'm done treating their horizontal canal beat, because I agree, there would look like there's some torsion there. And that's hard to reconcile with posterior canal involvement or with horizontal canal involvement. I would want to focus on the horizontal canal here and then probably at a follow-up visit, look at left Ixhalpike testing closely to see if they have a little bit of multi-canal BPPV, meaning left posterior canal BPPV also.
I like that approach because it definitely seemed like that horizontal canal involvement was pretty violent, and probably the more if there were symptoms, would have been the more symptom provoking issue. So treating that on that visit and then bringing them back for retesting to see where the chips fell type of a scenario makes a lot of sense.
If I run into horizontal ipsilateral, posterior, and horizontal canal BPPV in the same ear, I will treat posterior canal first that day and then horizontal canal, and that doesn't spook me because you're not putting the affected ear. There's treatments we can do where you don't have to put the affected ear dependent
if you're doing
the posterior canal. But when you got contralateral posterior canal BPPV and you got your ipsilateral horizontal canal BPV, I would treat whatever canal seems more involved, which usually the horizontal canal wins that battle. I wouldn't want to treat both those in the same day because you could be chasing your tail there potentially. Because when you do your, whichever one you decide to treat first, you're going to put that at risk when you treat the contralateral side, if that makes sense.
Makes sense.
All right, let's move on here to position 3. So now the person's going to roll completely onto their left side with their nose kind of pointing down towards that mattress at an angle. So it seems like we still have some continuation of that geotropic nystagmus.
But it decays.
But it decays, yep.
Pretty quickly.
And now it's reversing.
Mm-hmm. So we just, with those 2 positional changes, we did just induce a pretty good burst of geotropic nystagmus. So this could potentially, again, be central nervous system compensation.
To the other side.
Correct.
Yep.
Okay. So, I'll admit, when I first saw that, like the multiple times I saw this video, it wasn't until today talking to Jeff, where, he turns on that light bulb, that I would have also gone to the sense of thinking that there was also cupulolithiasis here. So it's tricky stuff, but, walking through this and kind of problem solving and breaking this down, it kind of helps to clear things up if you go slow enough. Does that sound about right?
Yep. The other comment from this video is, from only looking at this video, probably the right side's involved, but you really should do supine roll testing to discern clearly what side's involved, and then if needed, do a bow and lean test. And just so in review for people that aren't familiar with the supine roll test, the geotropic nystagmus should be more intense to the involved side than the uninvolved side. To judge that based on more than a sample size of 1 if you have a patient that's tolerant of it. And then if you're still not sure, it's very helpful to do a bow and lean test. So you have your patient sitting, and you can either have them bend forward at the hips or their nose is towards the ground. You want to go down 120 degrees. Because remember, our horizontal canals tipped up about 30 degrees higher in the front than in the back. So we want to bow 120. So you really want to get a lot of flexion of the head downward towards the floor. If it's canalithiasis like we're expecting, and if it's the right side, you should get a burst of right beating that's transient when you bow the head. The bow portion of the bow and lean is nose towards the floor. And then when you have the patient lean back, head extended, nose to ceiling, the nystagmus should again be transient and beat to the uninvolved side. So that's really helpful for lateralization with horizontal canal canalithiasis. It'll beat to the affected side when you bend forward. It'll beat to the unaffected side when you lean back. And the nystagmus shouldn't be sustained in one direction. If it were sustained in one direction, that would kind of steer you away from canalithiasis and make you think more cupulolithiasis. When you go back, by the way, it's back. You want to go back 60 degrees. So it's down 120, back 60. You're trying to get the canals aligned with gravity.
And if you were doing the bow and lean on a patient that had cupulolithiasis, the directionality would be opposite. So you would bow forward to get the unaffected side, and have them lean backwards to have nystagmus beat to the affected side for cupulolithiasis in this case.
Correct. And then nystagmus with cupulolithiasis should be more intense when their nose is towards the ceiling, because that's the excitatory nystagmus.
I think
it should be more when they bend towards the bow.
I think Rick Clandaniel says up with the cup. So look up for cupulolithiasis to remember which direction to test for the side for the affected side. I like that test a lot, actually.
Yep. You really need video goggles, I think, to do a bow and lean test. Otherwise, you're on the floor trying to look up at the patient's eyes. Like, video goggles are really helpful.
Could you see the compensation happen with bow and lean as well?
Yeah, the nystagmus with the bow and lean test usually isn't as intense as what you see with the supine roll test. So I see it less often then, but you can. Whenever you're dealing with that short-term central nervous compensation confusion nystagmus that we talked about, I honestly, like if I do a right roll test and I see a burst of right beats and then they go into left beats, if they're secure and their head's on the pillow, I'll come over and write their note for a while and just wait for it to go away and stop. So it's not polluting your next test. So don't be afraid when you think you're seeing that. And if your patient's secure on the table, just go away for a while and let it go away before you move the patient's head again. So it's not confusing your judgment with your next test. That's a good clinical pearl for any vestibular test you do. If you stir up a burst of nystagmus, like you do a head shake test, and the patient gets right beat nystagmus after we do a head shake test, just let that calm down completely. And that can have a compensatory phase too. So you want to wait that out before you go and do hyperventilation testing with the patient. Because if you do test consecutively too quickly, the prior test could be polluting your next test and really confusing you. So if you stir something up, let it calm down before you do your next maneuver with the patient or next test with the patient. I think that's a good piece of advice.
I think we saw a lot of instances on that video where I probably could have let that calm down a little bit first before we went on. And I think talking about the patient a little bit before, he was laid back and has gone through quite a bit of testing at this point that he could have tolerated that at that point. So it's a good clinical pearl for me for sure.
I definitely need to slow down because I'm totally guilty of doing this sometimes when you've got a packed day and your schedule feels cramped and you want to get through things. And Abby, we did, if you remember, an episode, I think way back when we first started Talk Dizzy to Me, where I actually had to go through a video with Jeff and he had to walk me through what I was doing wrong on this roll test of why it got so confusing, because it also involves central nervous system compensation and accidentally fixing a horizontal canal lithiasis with a roll test. And I'll link that in the show notes. It's definitely worth a watch, but I had to sit down and call Jeff and be like, what did I do here? And he had to walk me through exactly what happened. And again, light bulb moments, which is amazing to be able to have somebody to talk through this stuff with.
This is why we bring in the big guns.
Yeah. I'm 50. My guns are saggy. One other clinical pearl with this isn't published anywhere. This is just personal experience. If you start out, like almost all of us when we do positioning tests, start out with Dix-Hallpike because posterior canal involvement is more common. If you do Dix-Hallpike testing and you see a burst of geotropic nystagmus, usually the involved horizontal canal is the opposite one. If you look at modeling, debris in a horizontal canal is more likely to slide and move when you do a contralateral Dix-Hallpike, not an ipsilateral Dix-Hallpike. So if I have a negative left Dix-Hallpike and then I do a right Dix-Hallpike and I get geotropic nystagmus, I'm already thinking it's the left side. It's the other side. I found that to be pretty reliable. It's not 100%, but it's probably like 80%. You still need to do your supine roll test and may need to do your bow and lean, but start thinking it's the other ear when you see that.
That makes so much sense. Again, and that'd be perfectly applicable to that previous case that I had to come running to you for help with to figure out what I did. That makes a lot of sense.
The other thing that again, for a novice clinician, when you do a Dix-Hallpike, just because you see a flurry of nystagmus that crescendos and decrescendos doesn't mean it's posterior canal. You got to look closely at the eye movement. If you're seeing a horizontal nystagmus, the eyes don't lie. That's not being generated by the posterior canal. So I've seen some I have neurology residents that observe with me, and a lot of times when this scenario happens, I do a Dix-Hallpike and there's a burst of geotropic, and they sit there and watch it with me. I'll ask them, well, what would you do next after seeing that? And they're like, well, do an epley. I said, whoa. I said, what did you see? Well, yeah, but your Dix-Hallpike was positive. I'm like, yeah, but what type of nystagmus did we see? And they're like, well, it was horizontal. And I said, well, the posterior canal doesn't have the ability to generate pure horizontal eye movement. We need to think outside the posterior canal, and epley is a treatment for the posterior canal. So look closely at the eye movements when you test patients. Don't assume that it's always posterior canal.
And how many times do patients go to their first line of defense? They get tested in Dix-Hallpike. They immediately go to epley. Epley doesn't work. They wonder why epley doesn't work. And it's probably similar to that case that you just described.
Yep. Yeah, because then with the scenario we just went over, you're treating the wrong canal and the wrong side. If anything, you're probably, by doing an epley to the wrong ear, wrong canal, you're driving the debris towards the cupula on the horizontal canal on the other side. So you could be making that patient feel worse, because if you got a big wad of debris caught to your cupula, you can really feel pretty miserable. So it's generally good not to make patients worse.
Generally.
Yeah.
I don't think that's therapeutic.
No, not very. Well, this is exactly what I was hoping for out of this video. Dan, can you just give us some closure? Tell us how the patient did, how they're feeling these days, and what they're up to.
Sure. I talked to him yesterday. He's happy as a clam. He and his wife, they travel cross country in their RV. He just came back from Ontario. They've got their e-bikes out. He's feeling really good. So, ultimately, with all the maneuvers that we did, whether they be in the right progression of, maybe clinical guidelines would say that he did get better and he is thriving. I will have to make a quick plug for him because I always have to add in the human element to all this. We had gotten to the end of his treatment and he, again, we had talked about how this patient was relatively laid back, but you could tell he was getting a little frustrated with everything. So we did ultimately take a couple of weeks off, and we did that because, he was having some brief limitations in doing what he loves to do, and that's making guitars. So this guy owns, and you can check him out. I think we linked to the website, snakehillstudio.com. And he makes these amazing custom guitars. He made one from an old tree dating back from, I think, 1300 somewhere in Basking Ridge, New Jersey. And it's amazing what he does, and that's his true passion. So we made a clinical decision to say, listen, let's break on treatment for a couple of weeks because we want to see how things settle in. So luckily that ended up being the right clinical maneuver in that moment, was almost to leave it alone. And ever since, he's been feeling really good and back to what he's doing. And so grateful for a patient like that to allow us to do all these maneuvers and be really cool with, kind of experimenting a little bit and knowing that, hey, we're not going to really hurt you for the long term, but this is something that we need to go through to make sure we're giving you the right treatment. So.
And as a clinician, if you're trying to help your patient and you're doing your best to use clinical decision making to put them through things that should be helping them, you're doing them a favor than just leaving it alone altogether and leaving them to their own devices. So I think it's amazing. Thank you so much for sharing this video with us and coming on to talk about it. And Jeff, thank you for your clinical pearls and expertise and all those light bulb moments that you provided. It definitely shed a lot of a new light onto this video. We appreciate it.
I've got a couple closing remarks for our audience as well. If you have videos like this, they're confusing, they're a little intimidating sometimes, and you want
really
some help, or it's just really cool, yeah. And you want to talk about it, please feel free to email us. Email is Abby, ABBIE, @Balancing Act Rehab. We'd love to take a look. Maybe we'll do another episode like this. And also, if you like learning from Dr. Jeff Walter today, please check out his MedBridge courses. They are awesome. Thank you guys both so much for joining us, and thank you, audience.
Thank you.
Thanks, Dan. Thanks, Danny. And thanks, Abby.
Thank you. We'll see you guys again soon.
The information on this podcast is not intended to replace the care provided by your qualified health professional or to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on Talk Dizzy to Me. Please contact us at Balancing Act Rehab if you think you could benefit from vestibular therapy.